So, as rightly pointed out, exact IOL power calculation is the first and most important step in how to have near emetropia in all our cataract patients. See, in earlier times, cataract was removed first and spectacle prescription was given last. But today we calculate power of IOL first and cataract surgery is done afterwards. We all are aware of these two types of formulas, regression formulas and theoretical formulas. Since 1975, IOL power has been calculated using basically keratometry, axial length, and clinical history. But modern formulas require an estimation of effective lens position, and that is where the IOL is going to sit inside the eye, and it is calculated differently by each formula based on not only axial length and keratometry, but some other parameters like anterior chamber depth and some more parameters. So improvement in IOL power calculation are the result of improvement in prediction of the effective lens position. Major sources of prediction error for IOL power, the most important is ALP prediction, which accounts for 35% error, followed by axial length and keratometry. Axial length was the most important parameter which is fed in, and a measurement error of 0.1 millimeter would result in post-operative refractive error of about 0.28 diameter. So there is difference between ultrasonic pachymetry and the optical biometry. RPE, that is pigment epithelium, is the endpoint of optical measurement, whereas internal limiting membrane is the endpoint of ultrasonic measurement. So measurements taken by optical biometry are longer by almost 0.22 millimeter than those taken with ultrasound. There are definite advantages of optical biometry. It calculates right up to the center of the macula, and accuracy of axial length measurement with the ultrasonic biometry is 0.1 to 0.12 millimeter compared to 0.012 millimeter for optical axial length measurement. Then it's a non-contact method. You can get accurate assessment in pseudophakic eyes, more accurate measurements in staphylomatous eye in children, silicon-filled eyes. So we can, this measurement is done with optical biometry, where you have also telecentric keratometry measurement. You can have with either with IOL Master 700 or with LensStar, which have also the newer generation formulas which are incorporated. So the keratometry measurements are more accurate, anterior chamber depth measurements, axial length measurements are more accurate, although there is some concern in very dense cataracts, but the newer generation of optical biometers also take into account all these measures, which are the other important, second important parameter is keratometry, and 0.5 diopter error in keratometry will result in approximately 0.5 diopter postoperative error at spectacle plane. So keratometry becomes a very important parameter which is to be fed into the formulas, and it can be done with either of these instruments, manual, auto-K, Sheem plug, optical biometry. There is overestimation of power of cornea with different, there is different readings with different keratometer. Why? Because the cornea is prolate, and closer you measure to the center of the cornea, you get a higher reading because of the prolate shape. So you have to be aware that at what distance, at what diameter your keratometer is assessing. Like manual keratometry measures at 3.2 millimeter, auto at 2.6 millimeter, topography at 3 millimeter, orb scan can draw a circle at 2 millimeter, and also take inside that readings at different diameters, 0.5, 1 and 1.5 millimeter. Third important parameter is anterior chamber depth, and atypically anterior chamber depth is from the posterior surface of cornea to the anterior surface of the crystalline lens. But in optical contest, it is from the anterior surface of cornea to the anterior surface of crystalline lens, and in some formulas the measure ACD is used to aid in the prediction of effective lens position, as in Barrett Universal 2 formula. There were some hurdles in accurate estimation of effective lens position with the older formulas, because older formula had some basic assumption, that is, shorter eyes and flatter K eyes were supposed to have shallow anterior chamber and shorter effective lens position, in contrast to longer eyes and steeper K eyes, which are supposed to have deeper anterior chamber. But Holliday taught us that there are 9 types of eyes. Eyes with normal anterior segment, 80% may have short axial length and 90% may have long axial length. And in eyes with normal axial length, 2% may have short anterior segment and 2% may have larger size of anterior segment. So the relationship between anterior segment size and axial length is not proportionate in 80% of short and 90% of longer eyes. So older formula are bound to fall in short and long eyes. Earlier formulas also use some other assumption, that there is fixed ratio of anterior corneal curvature and posterior corneal curvature. Cornea was treated as a thin lens with a refractive index of 1.33. Actually, it is 1.37. Cornea was treated as a sphere, but it is a prolate. This used to give us very good readings and result in average eyes, but not in atypical eyes, in short eyes, long eyes, and eyes which are flatter or steeper. So is it bad to just keep using the older formula? Yes, because with older formulas, only 1% of the surgeons achieved accuracy more than 92% within 0.5 diopter. So that is not a very good figure. So we have newer formulas which have come up, like Hoffer, Ladas, Olsen, Barrett Universe, True K, Hill RBF, Kane, VRV. So there are more newer formulas. Prediction theory says more the number of variables to describe an event, more accurately you can predict the outcome. So we have moved away from just 2 variables of axial length and keratometry in 1988 to more parameters. Like we have 5 parameters in Barrett Universal 2, 7 in Holiday 2, artificial intelligence is used in Hill RBF and Clark, and ray tracing is used in Oculus and phaco optics. And there are some factors to arrive at, intermediate factors to arrive at effective lens position. We are all aware of A constant, which was used in earlier formulas like SRK2 and SRKT. Haigis has a factor like A0, A1, A2, Hoffer Q, and Holiday 2 has anterior chamber depth. Holiday 1 has surgeon factor, Olsen has C constant, Barrett has lens factor. So these older lens constants like 118.4 and other constants, they were typically developed during later stages of regulatory process with short-term data with limited number of cases and when contact ultrasound biometry was used. So we need to optimize our constants, because if we keep on using the older constants and don't optimize, there will be some errors. So optimization can be done either with your own data. You can feed into this drhill.com, Higgins-Ulib website. And so you find that if you do not optimize within 1 diopter, your accuracy level as seen on this left-hand slide was just 50%. But if you optimize within 1 diopter, your accuracy jumps to 95%. So interoperative aberrometry is another technique. Ray tracing is another technique I'll not cover. There are limitations of ray tracing technique because they are still dependent on accurate estimation of effective lens position. So no reason to switch to ray tracing formula. This is Wang and Koch optimization, which optimizes all the older generation formulas. You just have to multiply by a constant figure and then you can have good results. But let us talk about the formulas which have become very popular. Barrett Universal 2 formula, it uses lens factor, which is dependent on keratometry, axial length, anterior chamber depth, lens thickness, and white-to-white measurements. Hill RBF uses artificial intelligence, and it gives you accuracy more than within 0.5 diopter in more than 91% of the cases. Hill RBF formula is self-validating. It not only gives you IOL power, it also tells you whether your accuracy level, whether your calculation in the bounds or out of bounds. Out of bound means the database does not have enough data paralleling your specific case to support calculation. But in bound means system has enough data to support. So you can find out whether your Hill RBF formula is going to give you good results or not. Let us compare Barrett and Hill RBF. Both are current, both are more sophisticated, although they use different scientific premises, but both will give you recommendations that are within 0.25 diopters of each other. Olsen is another formula which uses ray tracing. Ladas is a very intelligent formula. It combines the best performing portions of multiple 3rd and 4th generation formulas. So you can have accurate result by using Ladas formula. Kane formula is another formula which has come after Barrett Universal 2, and it also incorporates artificial intelligence. And beside axial length, keratometry, anterior chamber depth, it also incorporates sex of the patient, because they find that the male and female sex will have some different parameter of axial length and keratometry. EVO 2.0 formula is another formula which is a thick lens versions formula. It also incorporates, besides all these factors, central corneal thickness. So what should I do? Sometimes I get confused. Should I use multiple formulas and average the results? Douglas Koch says, yes, use multiple formulas and then average the results. But Holiday and Barrett says, use specific formulas for specific situations. You don't need to average the formulas. What is the best way to deal with short eyes? Previously, we always thought that Hoffer Q formula is the best formula. But now what has been found is the newer literature says the Kane formula, the EVO formula, the Barrett Universal 2 is a good formula to be used in the short eyes. Problem in longer eye is that we get hyperopic surprise when dealing with eyes more than 24 millimeter. So these are some of the formulas, and all these formulas are available free and they are available on site. You don't need to buy expensive equipments for this. And this is the meta-analysis which has been done. And to summarize, you will find that the first 5 more accurate formulas in shorter axial length more than 22 millimeter and in longer axial length more than 26 millimeter, you will first be surprised that SRK2, Hagees, Hoffer, Holiday are nowhere there in the first 5 more accurate. The most accurate are Kane, EVO, VRF, Barrett Universal 2, Hill RBF, and Pearl DGS. So these are the formulas which you have to really turn on to have more accurate results. So what are the steps you can take to maximize likelihood of getting better outcomes? Please optimize your lens constants. Validate your measurements if you are getting readings which are not as expected. If you are getting ultrasonic reading less than 22 or more than 25, keratometry which is less than 40 or more than 47, and difference between the two eyes is more than 1 diopter, please validate and check again. Take measurements yourself, because in atypical eyes, because ophthalmologist is the most knowledgeable person in atypical eyes, do not depend on your optometrist. Don't remove yourself from the process. Spend extra time counseling patients with short eyes, long eyes, and previous refractive surgery. And don't just keep using older formulas and then you don't know whom to blame. Please be informed about the latest developments. 90% within 0.5 diopter is achievable. But why we are stuck at 90% and not more than 90%? Because now the problem is not the formula. Problem is the least count of the measurements. And the precision limit for keratometry is 0.1 millimeter. Precision limit for effective lens position is 0.3 millimeter. So these are the least count which are keeping us within 90% and not more than 90%. Then there are some measurement errors because ISO permitted tolerance for various IOLs is also there. Imagine you have calculated power of 21.3. So the nearest IOL available is 21.5. But ISO permitted tolerance for this 21.5 is 0.4. So you wanted to implant 21.3, but actually you are implanting something like 21.9. So you have got an inaccuracy error of 0.6 diopter without any of your fault. So don't blame yourself for everything. So there are different sets in pediatric eyes and elderly patients. This is the chart which gives you accuracy range of these formulas. You'll find Barrett, Hill RBF, Kane, they are accurate in all the various lengths of the formula. So does one formula fits all? And these formula, if you find that one formula for all types of eyes, Barrett Universal 2, Hill RBF, Kane, Hill RBF, and Kane. So in more complicated cases, such as patients with short or long eyes or history of previous corneal refractive surgery, comparison with at least 2 of these newer generation formulas is going to help. So improvements in technology have allowed accuracy of biometry to double every 5 to 10 years. 80% is acceptable, but 90% is achievable. So strive for what is achievable and don't be tolerant with what is acceptable. And to increase level of accuracy, use validated measurements, optimize lens constants, and adapt to newer technologies. And for achieving these level of accuracy, we should be grateful to these ladies and gentlemen like Holiday, Wang, Koch, Warren Hill, Thomas Olson, and Barrett, who have given us to enjoy this level of accuracy in our IOL power calculation. Thank you everyone for your kind and patient hearing.
Thank you, Dr. Bhalla, for just such an extensive overview on biometry. So one thing I'll just like to ask you, that if you give us one formula, like which fits in the most, like when you say 90% of an accuracy, what is the take-home message out of it, that which should be fitting the most of the eyes?
I've now started using mostly in all my patients Barrett Universal 2 and Kane. And these formulas you just have to download and in any of your phones also, feed in the data and you'll get the reading just within 1 minute. Even if you don't have optical biometer, don't be disturbed. You can have very good axial length measurement with immersion, and then feed in your data into your phones, and you'll get the reading with Barrett Universal 2. Same is true with Kane. You can have this thing, estimation of IOL power with these two formulas.
Even it very well fits in the extreme of the eyes, the very shorter ones and the very longer ones.
Exactly, exactly.
So the second enigma which lies with most of us, because now in the newer generation, as the age is advancing, and our LASIK patients are actually increasing, and we are getting lot of post-refractive surgery eyes. So how to actually go about in these cases is again a big dilemma, that what is to be done in post-RK, post-LASIK. So is there any particular SOP you follow for these patients?
Yeah, here most important thing is estimation of the keratometry. So keratometry you can do either with, I think here you required corneal topography, you do Scheimpfleck testing so that you have the accurate power and the access, and then these you can feed in your data. ASCRS calculator is very good guide, and then you can also use Barrett True K, which I think we do these two, and then you can see the average, the results, and depending on that you can decide.
Yes,
So,
Barrett True K is the most well accepted and most accessible thing, where you don't have to do much, and any of the equipment, the optical biometer where you have an access to Barrett True K gives you a bang on calculation. And secondly, the ray trace formulas like the Olsen and the Oculix also give you a very good overview. And in fact, in these eyes, I would say that none of the single formula would fit the best. So actually, we must take an average out of multiple formulas, and as we optimize our A constant over the period of time, we see that how and which particular IOL power is fitting in in most of these, and which formulas goes the best. So you take an average out of most of these, and then you are almost at your 90% accuracy.
exactly.
Can I ask one question? It's a very simple question. In many patients on auto K and IOL master, again do two times, three times, same reading is coming and they are different. I don't have the access to the pentacam. So what should we do? Which reading we should take? There's a difference of at least one diopter between two types.
I think here we also have to be aware that the ocular surface disease has to be optimized. A lot of these patients where you get different keratometry readings even on repeated examination, please don't do IOL power calculation on the same day. Put this patient on good lubricants so that you find that the optical surface is nicely optimized, and then you do keratometry maybe after week to 10 days. You will be surprised, you get different keratometry reading after you have treated their ocular surface disease. So that is what I follow, because if you keep on getting different readings on the same day, don't take that reading. Treat this patient for ocular surface
We have
disease.
given lubricant for 7 days. Still, it is almost similar. There is a slight change, but reading in the IOL master and auto K are still different by 1 or 1.2.
Then I'll go with the IOL master.
No, sir, I would just add on in this that you need to optimize your equipments for that. There may be an error with the calculation of your IOL master. There may be an error with your autoref also. So better is you go in for multiple instruments in these cases and try to see that which of your instrument is giving a better accurate reading, and try to optimize that. Because all these instruments, they definitely need a regular calibration. And we in our busy practice sometimes just forget over it that when was our last equipment calibrated. So these may you not, I would say that go with one particular thing blindly, but just try to optimize your equipment and understand that which is giving you a better reading.
IOL master we normally optimize once in a week. It's a compulsory.
Yes.
And same thing happening with immersion biometry and IOL master. Axial length is different from immersion. Not the standard expected one, large difference.
There is always a difference between an ultrasonic A constant
No,
and
that
an
is there.
optical A
I'm
constant.
taking
And
into
that
that.
is that is because of this kind of a difference itself.
In the axial length measurement.
In the axial length measurement, because ultrasonic may give you a little different reading, as it does not go up to the depth of the RP layer, and as compared to the IOL master, which will give a little extended one.
Yeah, that is there. Taking into account of this factor, still there's large difference because axial length is an important parameter. Suppose there is a big difference between immersion and IOL master. Should we go for IOL master?
Again, I'll go with Piyush. Then if there is a large error, it should not be there. Then I
Large
think
should not be there.
It should
A
not be there.
minimal
Small error
is
can be there.
understandable.
Then we have to optimize our this thing equipments. We have to calibrate. Then something is there. Large
you.
error should not be there.
Thank you.
So can we have the next one?
Just add one thing, Dr. Bhalla. All reading should be taken in undilated pupils. So it should be
Very
avoided
true.
in dilated pupils
Very true.
because you get more errors with that.
I think keratometry should be done the first thing before you put any drops on the patient's eye. That is because things may change. So always see to it that once the patient enters and you have to do this cataract workup, it should be a virgin eye where you have not put any drops inside the eye.
So